after that session that we had, that also involved talks on morphology and on the current classifications, WHO and ICC, we really got into a very nice discussion on the criteria for diagnosing and risk stratifying MDS. And I guess or at least my takeaway from the discussion is that clinicians and researchers in the field may have very different expectations on what a classification should actually perform or what its intended use is. We have some classifications that define disease entities, ideally on a biological rationale. So identify patients that have biologically similar diseases. That doesn't necessarily mean that these patients may all have the same prognosis, or vice versa, that different disease entities always have different prognosis. So a prognostic classification is not necessarily the same thing as a classification of biological entities. And then a third necessity is to have classifications that help us to decide on treatment, which patient will profit from a specific treatment approach, from a specific drug, from an approach such as allogeneic transplantation. That is yet another level of how you may want to classify your patients. And current classifications such as the WHO or ICC may not necessarily perform equally well for all these tasks. So probably, although this means complexity is increasing, this is something that we as clinicians will have to live with. We will have biological classifications, we will have different systems for risk stratification, and we will have systems to look for targeted or risk-adapted treatments. Now, with that in mind, I still think that also the disease classification, the classification of entities, currently is the WHO and the ICC, is going to evolve. I just said that right now we still need to have morphology, but we can also identify some patients who have very little dysplasia, who do not fulfill the criteria for MDS. So they currently would go into the CCAS, clonal cytopenia of uncertain significance category. But these patients, if you look at their risk by the IPSSM score, you will see that they are quite similar to some MDS patients. And also, if you look at the actual outcomes of these patients, it resembles MDS. So we can identify a subgroup of patients who are currently classified as CCAS, who behave more like MDS. And that probably means our definition of MDS in the future is going to evolve. And my prediction is that we're also going to include some patients who don't fit into the current criteria because they don't have a lot of dysplasia. We will include them into the MDS category purely based on the genetic findings that we have. What are going to be the precise criteria for that? I think the jury is still out on that, but I think our classifications are going to evolve in such a more comprehensive way, and we're not purely going to rely on cytopenias and dysplasia, but we'll also integrate NGS results as an additional diagnostic criterion.